Hey everybody, welcome to another episode of the Exercise Mechanic Podcast. Today we are joined by Dr. Christle Guevarra. Hopefully I said that correctly. She's a primary care sports medicine doctor as well as a team physician for U.S. figure skating. Welcome, Christle. Thank you so much for being here.
Oh, thank you so much for having me. Looking forward to it.
Yeah, me too. And, before we started recording, we were talking about GLP1 and weight management, which is very, very pertinent conversations that the world is having as of late. And we definitely want to pull on that thread. Yeah. But before we do, selfishly, I would like to know who was Christle before Renaissance periodization exploded.
Gosh.
So you can take that wherever you'd like. I'm curious.
Oh boy, it's hard to say where the Renaissance periodization exploded because I feel like it's been in multiple places at multiple points in my career. I mean, I grew up in California. I grew up in the Bay Area. I was had periods of being a good student, being a crappy student, sort of fell into university and found, a love for chemistry and math. And so that's what I ended up majoring in. I left California to go to grad school for organic chemistry at the University of Wisconsin at Madison. And that's where I kind of started to realize, making molecules is super fun and super nerdy. But there was something missing, and I really just missed interacting with people and felt like there was something else I could do to help people. And which really meant I wanted to be a part of a patient's care and help manage their medications and help get them to a better place. And so I left the PhD program, got my sort of, consolation prize master's degree, and then kind of applied to med school and had a lot of fun in med school, didn't know what I really wanted to do. Loved everything about family medicine because you didn't have to pick just one particular kind of track. You got to learn everything from babies to adults to geriatrics to pregnant women to kids. And so I kind of went, all over the country. So I went to med school in Southern California. I did my family medicine residency in Philadelphia. And then I decided I really love working with athletes. I want to kind of pursue that. So I went to Vegas for a sports medicine fellowship. And this was sort of around the time that COVID hit. So Scott, the video guy, and Mike moved to Vegas and really worked on the YouTube channel while I was trying to navigate sports in, the era of COVID. And I think that's when the YouTube channel really started to pick up, is because they were just diligent and consistent about getting those videos out, all the time. And then I guess once we moved back to Michigan after fellowship, started my telemedicine private practice, and then started actually interning, if that's what you want to call it, at RP, in the marketing department. I started off counting Instagram posts, for all the sponsored athletes. Like, I started from the bottom, not just, oh yeah, I'm a physician, give me something special. No, I learned how the department worked. I kind of floated from project to project and kind of made sure that whatever I did, no matter what task, too big or too small, that I made sure that I did the best job I could, learned as much as I can, and left it better than when I started. So that's kind of that's a lot. It's just, I didn't know where to actually take that, especially when you get to, I'm 42 years old. Once you get past a certain point, you're like, what did I do with my life? Where have I been?
That's so funny. So there's one thing, I think I may have cut you off there, Ryan and Christle, but there's one thing that you said during your, when you were talking about your studies, that for me just cemented that you're a flaming nerd, which is that you used the word "get" when you were talking about how I get to learn about babies and pregnant women and kids, and you know what I mean? And I think that's really, that probably speaks a lot to the fact that you're very much driven by curiosity, and that's, I guess, that's maybe my, if I had a crystal ball. Oh, crystal. It's a crystal ball. My guess would be that you're a very curious person and that you really love what you do.
I would thank you for pointing that out. That was a really good catch. I think that the last couple of years, after being chronically sleep deprived through medical training and just focusing on mindset, because I think before that I would just said something to the effect of, oh, I have to learn this, or I have to do this, or I have to train today, or I have to eat right. So that has been very much a learned skill that I have been actively working on in the last 3 years or so.
Cool. Very cool.
So we kind of spoke about, obviously, you've gained a bit of a reputation recently as somebody who's speaking about the GLP-1 agonist drugs. I believe recently, was it the Evolve conference that you spoke at? Yeah. In Edmonton, I believe.
Mm-hmm. Yep.
So obviously that's a topic that we wanted to discuss today and get into a little bit. But when we're talking about weight management, something that we had talked about actually prior to you coming on the call was the role that genetics play in weight management. So before even we get into the pharmacology side, can you maybe discuss genetic factors, even lifestyle factors, while they might be obvious, I think it's worth discussing those components of weight management first.
Oh, yeah. No, definitely. I think to sort of keep it, I know there's a lot of nuance that we can go into it, but I think to sort of keep it simple and, for listeners out there is, I think, as far as genetics go, thinking about like how much of a food drive somebody has, their hunger signaling, what is that drive to eat? That's like kind of mentally in there. And then also thinking about what kind of calorie intake does somebody have in order to either maintain their weight or lose their weight. Obviously, gaining weight also has its things to consider, but for this discussion, I think thinking not enough people talk about maintenance calories, and I think it's a sad, state of affairs when I, for one, did not understand the whole concept of maintaining weight and until RP, actually, until I first read like Renaissance Diet 1.0 when it first came out. I was like, so I think those are the two big things that are involved with when it comes to weight management and weight loss. And so for some people, the drive to eat is just super high. You're thinking about food all the time. You're hungry. You it may not just be psychological. You could also have, physiological, signs. Your stomach's just growling all the time. And then thinking about what kind of not everybody. I think this is also a myth that I'm starting to realize that is perpetuated throughout the general population, is that if you're muscular or if you're fit or if you're super active, you should at least be able to eat 2,000 calories a day. And that's not the case. Some people maintain their weight on a lower end of calories. I've seen people, depending on the size of the person, you may be maintaining your body weight at 1,300 calories a day. And, for some people, that's totally okay. But when you have people who are, with a family history of being overweight, you were born a bigger child like I was, you're already expecting to kind of, have this higher food drive. You're expected to be at a higher body weight. Your body's already primed to be like, okay, I'm, going to be 20 pounds heavier than, my peers in class. So I just sort of expected that kind of throughout. I noticed that throughout childhood was, I was always hungrier than everybody else. I was always the shining, neighbor who, when you invite me over to eat, I would always clean my plate, and all the parents would be like, "Oh, look at Christle. She finishes her plate. Why can't you finish your plate like that?" Well, one, your daughter's got a low food drive, and two, she's much thinner than I am. So trade-offs here.
Something I was going to ask too, when you're talking about the psychological component, would you say that you notice, I know sort of my opinion just based on the clientele that I work with, but do you notice major differences in that area, like male versus female?
In terms of food drive?
Food drive, yeah.
Are we talking about just if they are like at a maintenance calorie, or if they're trying to purposefully lose weight, or some combination of both, or just...
I would say, just kind of in a general case. So just to give you kind of my perspective.
Yeah.
Now, I will say, I think the clientele and the people that I'm exposed to is obviously a very unique population of people. When you're dealing with like bodybuilding men, quite large, there's probably pharmacology at play.
Yeah.
I think their experience is often they are spending so much of their time almost forcing food. So the food drive actually becomes quite low.
Okay.
Whereas typically what I have found with a lot of the women that I work with, even in a period of, higher food, like deep into an off season, that food drive and food focus kind of never goes away. So like a conversation, for example,
it's really interesting.
I had said something once where I'm about 15-ish weeks into an off season now, where I was like, if I didn't eat, I would feel fine. Like I don't really want to eat that, but I will. And I've had clients be like, I don't understand how you could say that. And they themselves are like 20 weeks into an off season, 25 weeks into an off season. And they're like, I wake up and I think about food no matter what.
I honestly, and I don't work with any bodybuilders. I don't have actually any experience working with bodybuilders other than, in terms of contest prep. But for the general population, the intermediate and even novice lifters that I kind of work with, I haven't seen like huge differences based on gender. So that's a really interesting point, and I wonder, like, it'd be like even when they mass, you don't necessarily see like, in an off season. I don't know how far you push the off season growth or how many calories they're on. Wonder how like. I wish I understood that I like the idea of eating so much, like that my food drive would, never go away. But then again, I am somebody who is on medication right now to quell that, get rid of that food drive that, like, I guess now I would be able to say that, like, I understand.
I have a follow-up question for you when we were talking about the role that genetics plays.
Yeah.
When let's say you're working with a patient, how do you tease out or try to maybe quantify the influence of genetics in comparison to how much of this is learned and lifestyle and environment? Like, how do you work through that? Because that feels really messy. To me.
I don't necessarily think that when I actually don't. Like, I guess in my head I might, but I would never, I don't think that's actually, I don't think it would, you're right. It would be a very messy down the road kind of, a kind of road to go down. And I don't think it leads anywhere. I think what's really important is to try and work with them on their lifestyle and also give them hope. And I feel like with a lot of this whole conversation about weight loss with drugs, I remember being in sort of, feeling hopeless. And it's especially hard when a lot of the lifestyle behaviors that we are endorsing are thinking about things in the long term, having delayed gratification. People's timelines and expectations are just so out of whack. So anything I can do to kind of keep that positive mindset, even when times get tough, is really the key. So I never really talk about genetics per se with patients who are thinking, who I'm mostly managing or helping them coach through lifestyle stuff, just because I don't find it to be helpful. I think it's interesting to look at down the line. I probably wouldn't have really enjoyed that conversation at 190 pounds. Like, oh yeah, you were born 8.5 pounds, like, from, a 4'10", mom who weighed 180 pounds. Like, how is that going to help me? Like, I'm already in this shitty position that I don't want to be here. Like, I hate myself, my joints hurt, and I'm snoring, and I'm not getting good sleep. So,
yeah, yeah. Why do you? It seems like there's so much shame around the use of pharmacology to help with weight management. Can you speak to that? I'm curious. I mean, from your perspective, as someone who's not only you're how would I say, you can have a stance on this from a very interesting perspective, because you're both a physician who supports people, and you also are someone who has benefited tremendously from it. So I'm curious what your thoughts are on that.
So for the record, I prescribe these medications to other people. I have a doctor who prescribes it to me. So I am both a physician and also a patient. And it's just a lot of feelings, because it's just a lot of feelings. And what I mean by that is, prior to starting GLP-1 agonists myself, I had failed a lot of other weight loss medication drugs without an issue. Like, I didn't have for whatever reason, and I really can't tell you why, but I was put on Topamax, I was put on Contrave, I was put on bupropion. I want to say that's down the list, but like, these are all oral medications that you take every day. And I had side effects from them that were terrible. I broke out into hives. I had noticed word forgetfulness with Topamax. And I actually got even more aggressive, or felt even more aggressive, on bupropion, which is an antidepressant. And stopped all of those. And for whatever reason, when a physician finally recommended, hey, there's this new drug for weight management, like semaglutide, you should consider it, I initially, for whatever reason, just said no, not at this time, I'm not ready. And I don't know if it's the needle thing. I don't know if it's, honestly, I wish I could tell you personally why I was not comfortable with it, or why I felt shame with it, because I did very much freely take all those other medications. I know a lot of people, including myself, there's some, like, ego is probably it. Like, I can do this. I can just willpower my way through this. Why can't I just be more disciplined?
Yeah.
For some people, feels like it's cheating. And I guess if I tried to compete as a natural bodybuilder, that would technically be cheating, because I think it's on the banned list of medications, from what I had heard. So I think there's and a lot of people just come from a place of not understanding, because people don't understand food drive, and people don't understand, like, calorie intake. Those are the two big things that kind of drive the boat forward. And if you have a high food drive and a low maintenance threshold for calories, you're kind of like,
It's rough.
Yeah, it's a rough road.
Also, just for the sake of clarity, as we start to get a little bit further into this conversation, can you describe exactly what GLP-1 agonist drugs are, and like what the mechanism of action is?
Yeah. So the GLP-1 is a hormone. I might be butchering the pronunciation. It's an incretin. So it is, when we ingest food, it goes down, hits the small intestine, and the small intestines, signal that, like, we need insulin from the pancreas. So it releases two gut hormones. It actually releases gastric inhibitory peptide 2, GIP, and then glucagon-like peptide 1, or GLP-1. And they have a whole host of signaling effects. Most commonly, it signals to the pancreas, we need insulin. But there are also receptors, GLP-1 receptors in our brain, that controls satiety. And so that's where some of that, food focus, decreasing that food focus comes from. And then the other part is it actually slows down gastric emptying. So, it'll keep the food in the stomach a little bit longer, which also helps with satiety as well. So those are the two main mechanisms for why people end up, feeling like they just don't want to eat anymore when they're on it.
It's really interesting. So it's almost like there's a bottom-up and a top-down mechanism from this one thing, so to speak.
Right. So
that's really cool.
And I think most people are familiar with Ozempic. It gets the most marketing.
Yeah.
Which actually, funny enough, I was in New York a couple of weeks ago, and there's a very significant difference with pharmacology marketing in the US versus Canada. Ooh. I honestly don't see any signs up here in Canada. I live in Ottawa. Mm-hmm. And in New York, every like subway stop, like every bus stop, there was ask your physician there about Ozempic. There's literally people like shooting themselves in the tricep with it. I was like, this is crazy. And the marketing it almost looked like they were selling like Guess jeans. Like it was crazy. Anyway,
it's like the marketing is don't like your jeans. Ozempic.
Oh, boom.
Bunch. It's the second one today.
The ads for Ozempic are crazy. It's just like, people gardening or like doing everyday things and like, oh, hey, let me talk to the camera. Like, I lost 15 pounds on Ozempic.
Sorry to cut you off, Ryan. If I may, are there any downsides? Like, we were talking about how it seemingly like it has top down and bottom up. Mm-hmm. It's positive, but like, are there any downsides?
Oh, yes. With every medication, so not just, just in general, there are always going to be side effects to, have to manage and deal with. And, any type of adverse reaction, like meaning like you may just not be a responder, which is definitely a case. So I think it's always just important to keep in mind. And, I love this question because, it is not an end all be all a solution for everybody. So one of the most common side effects is nausea. People feel really nauseous, and that is, a huge downside to the GLP-1 agonist medications. Seemingly, a lot of people who complain about nausea might better tolerate tirzepatide or Mounjaro, Zepbound, which not only targets the GLP-1 agonist receptors, but also the GIP agonist receptors. And so, so that might potentially be a solution to that. The other things that people complain about or can complain about that are a little bit more serious but less likely to happen, gallstones, pancreatitis, and I wonder if that is, more of a side effect due to the really drastic crash dieting that people have on the drug, because that's also a potential thing to watch out for people who have had bariatric surgery, who undergo very, drastic weight cuts after their surgery, their post-op. I've seen a couple of post-op surgery patients, and looking at what their kind of stepwise kind of approach to diet, their instructions are just a little maddening. I've seen people, stay at 800 calories for as long as you can as a maintenance plan. And so I wonder if part of that has to do with the fact that, like, you used to eat 2,000 to 3,000, 4,000 calories a day, and now you got surgery, you are now on this 800 calorie a day diet. Higher risk of gallstones in that case.
Interesting. Sorry, I didn't mean to cut you off, Ryan. Go ahead.
One thing you were talking about just with the drastic weight loss, the phrase that I've heard people use is Ozempic butt. I don't know if you've seen this.
Yeah.
Which I think it's probably like typified by, I think like Hollywood people that go on Ozempic and then, essentially just like lose any kind of curves that they might have.
Yeah.
I think we kind of know the answer to this a little bit, but how would you instruct somebody to avoid that sort of crash diet tendency that people might have on a medication like this?
Man, I hope, and I feel like at the Edmonton conference, bridging that gap and having more fitness professionals, more online coaches, sort of figuring out a way to team up with physicians is just going to be the key, because we as physicians just don't have the way that the American medical system is set up is not conducive to really helping patients figure out the behavioral stuff, the lifestyle stuff that is what these people really need versus, the medication is important, but it is a very small part of the equation. And I just don't want people to sort of forget that. So it's hard when you have somebody who isn't really sold on the process. I find that is super difficult and super challenging to kind of, if they're not, it's hard to it's a hard conversation. You can always continue to build rapport and kind of see where they're at. You don't necessarily have to, crank up the dose to the max, GLP1, like the whatever highest dose possible to kind of help with that. But I think also just having an honest conversation, like where do you want to be? Like what do you want to, Ozempic, I guess being real with them, and Ozempic but only happens with people who crash diet, but I think it's easier said than done, because I do know people who have said to me at certain points, I've been overweight all my life, I have had food noise all my life, and now for the first time I don't have food noise, and I never want this to stop. Like, I never want this feeling to like go away. And so to try and sell people on like, maybe you should try, kind of adjusting your dose so you can get all the nutrients in so you can build this muscle. If I had a solution for you, I would, but it's hard when somebody is still thinking like that, right? So
as a follow-up to that, obviously, we can see the sort of short and intermediate effect that having this kind of medication in place could have. What are the long-term ramifications? What would be the long-term intervention with something like this? Like, would this be something where you would have kind of a pharmacological intervention until they were at a place where they could maintain their weight? Or is this something that someone's potentially on like for years on end?
So we have had this class of medication has been on the market since 2005. Not particularly semaglutide, not particularly Ozempic. That came out in 2017, I believe. And we've had liraglutide or Saxenda since 2014 for if FDA approved in America for chronic weight management. So having people on this for long periods of time, I think is totally reasonable. In terms of, I think it can be dealer's choice as to whether or not people want to get off of the drug, but I would also be sure to have that conversation with a lot of people who, not everybody, but a lot of people who come off the drug. That food focus does come back. Some of the weight comes back. And I think if people know that ahead of time and still want to give it a shot and try it, I'm kind of all for it. I'm really all informed. Like, at the end of the day, it's not my choice whether or not this person needs to be on this medication unless it's incredibly life-threatening.
Something I've thought of, and I don't know if, feel free to agree or disagree with me on this. Because again, like we've talked about, there's this weird stigma around like using medications to help people with their body weight or losing body fat or something like that. And there's kind of this naturalistic fallacy sometimes that exists.
Yeah.
I liken it to people being on blood pressure medication, where risk reward of being a blood pressure medication errs on the side of you're probably better off taking a medication and having low blood pressure versus just having chronically high blood pressure and not taking any drugs. In the same way, I would imagine being chronically obese, for example, probably carries way more health risk long-term than potentially being on a drug and having a lower body weight. Is that something you agree with?
In general, do. In general, I do. With that said, though, the lower blood pressure, I'm really trying to figure out like an example of like why I wouldn't agree with that. Off the top of my head, just not to be like, argumentative, but I think it's also important to kind of see like, man, where have I really like botched something and things have gone wrong? Because I've seen people with really low blood pressure and you're like, do we need to go in the higher opposite direction? And because if people have lower blood pressure, I feel like, yes, the opposite. If I had to choose one, I would take the lower blood pressure and then the high blood pressure. But also in general, the risk reward ratio for somebody being on something like Ozempic is usually the benefit outweighs the risk.
I'm curious, what would be, so let's say a patient comes to you with the request of wanting to go on semaglutide or, another similar drug.
Yeah.
What might be some of the red flags that would lead to you perhaps not recommending it for them?
It has sort of changed. I think it's always depending on people's comfort levels. I think if there is potentially some sort of there may be something going on psychologically as to why they're eating, and not necessarily like I feel true hunger. Like there is, I have a stressful life situation going on right now, and that's like I'm causing to eat a lot. I think it's worthwhile to, hey, like maybe you need to talk to a therapist or talk to a psychiatrist or a psychologist. That part I've been a lot more hesitant on, starting a medication. Obviously if somebody's body composition, they're, already super skinny, and they're like, I need to go on this, I'd probably kind of start teasing out the why. I was on TikTok and I want to be, I don't know what supermodel these days is super thin, but if you're already at a pretty reasonable body weight, I'm not sure how comfortable I am with that personally. So those are kind of the two bigger, like, red flags off the top of my head where I'm like, it's hard for me to say yes to this at this time.
So what criteria would qualify somebody for a prescription?
So typically as far as what qualifies them to have it covered by insurance, it is, if you're diabetic, because these medications do treat diabetes, even pre-diabetes, I think the BMI cutoff is 27. With like plus or minus some comorbid conditions like high cholesterol, high blood pressure. Thankfully, knock on wood, that hasn't been a huge barrier for me, but I am a little bit selective on who I take on as a patient. So I know in the past I have had people who, because insurance in America is just wonky, I've had people who should have been on it, who definitely needed it, who had trouble getting it because whatever insurance company you had just decided, like, we're not covering this, and we're sort of at the mercy of whatever it is the insurance company decides to do.
Yeah, that's really interesting. And earlier we were talking about individuals who go on the drug and then crash dieting, and the importance of talking about the long game. And one of the things that you had mentioned there was the role that fitness professionals play, teaming up with physicians. And that was one of the things that for me seems, as a trainer, is a very relevant question that I have, which is like, well, okay, as a trainer, when I inevitably get a client who is on a GLP-1 agonist, how does that affect the role that I play in terms of like how I coach them? Do you have any thoughts on that?
Yeah. Definitely you guys have a huge role to play. I mean, you guys spend more time with your client, like with these people, than myself or anybody else. So I think checking in with them to see, like, how are they feeling? Are they feeling nauseous, during this session? Have they felt nauseous this week? How have they been eating? Like, do they feel like, are they actually getting their food in? Or are they like, I'm on this diet, but like, if I just eat a little bit less than what, is recommended to me, like I feel even better because I'll lose more weight. Because I know that's a huge thing with, a lot of the general population. And now I have this medication that takes away food drive. So I'm just going to not eat shit. And so, just seeing how they're feeling overall, because I know constipation is also a thing because they're not eating. And if they are having symptoms of like, I'm throwing up all the time, like I can't eat anything, my weight is down like a ridiculous amount because now I'm also dehydrated because people forget to drink. hey man, maybe it's time to like talk to your doctor and like think about adjusting the dose of the medication, or, you know, trying to be an advocate for your client and encouraging them to continue to have that conversation with their physician of like, hey, maybe we need to back off a little bit. Like, I think this dose is too much, or maybe it's too little. And, you know, having them kind of, you know, be proactive, because I also think sometimes physicians do just sort of like go straight to the highest dose possible and think like that's great. And it's like, some of us don't need that. Some of us don't need like the maximum dose possible, because I know the ramp up is, you know, you start off at 0.25 for semaglutide, and then every 4 weeks you go up. Sometimes you don't need to go up. Sometimes you do. It really depends. And so I think it also forces me as a physician to stay on my toes and really make sure that like, hey, like you can't just like, you know, give them the highest dose possible and then be like, oh yeah, follow up with me in 6 months.
Something you kind of said this, you know, maybe 15 or 20 minutes ago, and I sort of bookmarked it for later. You had alluded to something along the lines of just like the type of communication you'd have with a patient. Yeah. And I know this is something ET believes very strongly in, is like the type of language that you would use with a client or a patient, and that being a really critical part of their care, essentially. Could you kind of speak to that in general, like the power of language when speaking with a patient? And then B, something that specifically I wanted to talk about as well. I think I had heard you maybe say this on a podcast or something like a year ago. It was something that had stuck with me as somebody who's in kind of the bodybuilding world, is the negative experience that a lot of people who are on kind of the competitive side of that use some kind of pharmacology, and their experiences with their GPs, and kind of the onus on a doctor being able to actually like have a caring conversation. So part A, just in general, the language that you might use, and B, how would you navigate maybe a conversation with a potential patient who, not necessarily GLP-1s, but like in general, like performance enhancing drugs, like how would you navigate that conversation?
Yeah. Good questions. Can you repeat the first question one more time? And then, sorry, I got stuck. No,
the answer is no. There's memory tests embedded in the podcast. We refuse to repeat things. You
know, like if somebody gives you a list of questions and then, you know, they answer the last question, I feel like right now verbally I'm like, all right, draw PEDs.
Question one was essentially, how important is language and how you use it with a patient in terms of their care?
Oh, yeah, super important. And I think, you know, it's not just definitely always, you know, be professional and respectful, but I think there's also this added element of being mindful of what culture or who they are or what space we're working in, because the same language I use when I talk to college American football players is not the same verbiage that I would use at a figure skating competition. So you know, I do a lot more listening than talking, if that makes sense. So I'll ask questions, and just as long as you come in with an open mind and, you know, asking questions because you're genuinely curious about who they are, you know, that's how I figure out how, you know, this person, like, what do they value? Like, what is their home life like? What is their sport like? Then I can sort of figure out, like, how am I going to talk to this person? Is this person, you know, like a hardcore power lifter, and it's just like, all right, we just need to get it together. We just, you know, we're going to get this 1 rep max and it's going to be so awesome. Or is it, hey, like, you did a jump and you know, fell and broke your ankle. Like, I'm sorry, let's figure out how we're going to take care of this. We're going to get through this together. So I hope that makes sense, because it's not like a one size fits all, but it's a lot of, hey, how's it going? Who are you? Like, where do you come from? How can I be helpful to you?
Yeah, I mean, I think that makes a lot of sense. It's something, ET runs this internship, and I believe there's a component of it that talks about kind of the power of language when talking with clients. And I think it probably starts with listening almost always. And I think it's just the importance that the language we use, the tonality, etc., has a direct influence on their outcomes. the second question I had for you, and I'll use my own story here because I'm sure that many people in my shoes have had a similar one.
Oh yeah.
When I first decided to take bodybuilding seriously, and I always say, unfortunately, that usually means pharmacology is involved if you want to do it at a high level. I remember, because I'm a fairly responsible person, I was like, all right, this is the road I'm going to go down. I would like to not die.
Yeah.
So, like, booked an appointment, like, wanted to run sort of initial blood work, inform him, whatever. And I basically just got a lecture on not doing it. And I was like, look, I get it. Yes, I understand. I could see your reaction. I was like, I understand I'm taking a risk.
Yeah.
But it's a risk I'm going to take no matter what. Like, what I'm looking for here is, like, help me manage these risks as best as possible. And not, pardon my French, but, like, not fucking kill myself.
Yeah.
And I remember just having a really negative kind of like medical experience from that standpoint. So as somebody on the other side of that conversation, how would you navigate? So if somebody like me came to you and was like, hey, like, this is what I'm doing.
Yeah.
How would you navigate that conversation with a patient?
Oh, yeah. One, definitely you are not the only person that has had that story. I feel like, unfortunately, this is the same old, song and dance that I have heard from many people. And it's really unfortunate because we as physicians, I trained in Philadelphia, which is pretty much the heart of the opioid epidemic. And we had to learn how to use language like instead of a IV drug user or IV drug abuser, we had to use somebody who has substance use disorder. And so we spent all this time, thinking about this flowery language to not make the person feel like total garbage. And then when it comes to steroids, it's like we forgot all those lessons we learned about people who choose to drink alcohol every day and people who choose to inject heroin we just finally like lost it. So that part really irks the shit out of me. But, for somebody who has come to me, letting me know, and I've had people do that. I say, hey, I can't endorse this because, it is illegal, at least here in the United States. I'm not as familiar or comfortable with that side of things. I would probably recommend you talk to a coach who is very knowledgeable in reducing the dose and harm. But as a physician, I can help you with your blood pressure. I can help you with labs. And if you have high cholesterol, I can also help you with that. Or anything I can do to help you today. And I feel like that's sort of the extent of, I'm like, I will still support you in whatever it is that you want to do. But, I'm going to just have this conversation that, like, I understand that you're choosing to do bodybuilding, and that's totally awesome, especially since you seem to be somebody who understands risk. So I'm not going to lecture. I'm not going to give you a spiel on that probably ever.
And for those types of patients that come to you, what health factors do you typically see being at risk most often?
Blood pressure. Everything starts with the blood pressure. And to a very smaller extent, low HDL, the good cholesterol, particularly with some, depending on which anabolics you use. And then the other part is mildly liver enzyme values get a little out of whack, depending on what, genetics, also how much of a cycle, how long you've been running it. So those are pretty much the three main things that I see. And then doing dumb shit in the gym. So muscle tear, tear completely off the bone, tendon rupture. But I also see that with people who are untrained. So don't get it twisted that, just because you do steroids, like, you're automatically going to get that. But I think those are the biggest things. And all the health markers that come down the line, I feel like all really come from uncontrolled high blood pressure, which makes me even more upset that physicians will just give people a lecture and then somebody has, blood pressure of 170 over 100 and just be like, yeah, if you did steroids, you'd stop. Well, if somebody diabetic with an A1C of 11.6, their sugars are in like the 300s. Can you imagine how that would go? Like, yeah, if you just like kind of cleaned up your diet and like didn't eat like 10 Twinkies today, like your sugar would be totally fine. Like, that's a slippery slope to go down. So I'm not, it sucks that I feel like I'm in the minority here with where do we go from here? So where, that line of like, oh, you do steroids, so you're a bad person, you are going to get a lecture, and I'm not going to help you. So have a nice day.
Would there ever be any moments when, let's say, someone comes in and you feel like the caring thing to do is to push back hard on either a request for, like, them, a request from them for you to follow them kind of thing? Like, do you have any thoughts on that? Sorry, go ahead.
Like taking them on as a patient, so to speak?
Yeah, like, I don't know. Like, so when you were just talking about, you mentioned a whole bunch of really great things, but there was a few things that stood out to me where there were some really strong parallels in like the rehabilitative world. For instance, when you were talking about how like it's unfortunate that I feel like I'm a minority when it comes to having this understanding about these things and how you work with people. I sometimes feel that way with regards to me working with my clients. And all that being said, there are some moments where I found, at least in my, what I call practice with like a lowercase p, where sometimes the caring thing to do is to like really challenge them on something for the sake of like their long-term health. And so I'm kind of curious, within the context of PEDs, and someone coming to you for advice or questions, where would that line be for you where maybe you would actively push back? Do you have any thoughts on that?
Yeah. I have seen bodybuilders, people who are on who do use performance enhancing drugs, actually look sick, acutely sick, where so a very common thing in patients who either have lung problems or heart problems is they will talk like, when they're trying to talk in a sentence, it's a little difficult to complete a sentence without pausing to take a breath. That would probably be, that is definitely a, butt puckering kind of sign where I'm like, probably not a good thing right now. So, signs of acute decompensation. So, you're complete, like you're grabbing your chest while you're talking to me. You can't really breathe. That's probably when I would be like, hey, like you need to probably get some help now. I'm really worried about you. I'm worried about this, and this, and I think it's worth going to an urgent care or an emergency room to get that evaluated.
And in those instances, what do you think would be happening under the hood? Just like for those that maybe don't, like myself, who don't know as much about this as you do. Yeah.
So, somebody who's coming in short of breath, I don't know if they're in heart failure. I don't know if they're having a heart attack. They haven't described any other symptoms, thinking about like stroke-like symptoms. Those are the things. And with people who do have, like, we're talking about years and years of unchecked blood pressure, those are the big things that I worry about the most.
Yeah, it seems as though, from what you're saying, and almost overwhelmingly any other expert that I've spoken to, unchecked high blood pressure seems to be sort of the catalyst for almost all of the other downstream, like, negative health effects. There are obviously some others that are independent of that, but if you're talking about, I always say just like not dying young, that seems as though if there is one takeaway for somebody is like, do not let your blood pressure remain high for not even extended, but like even a short period of time.
Oh yeah. Yeah, definitely not a long period of time, only because it is the silent killer, and you could be normal, and because people feel normal, they're like, yeah, I'll take care of it tomorrow, or I'll take care of it next week, and then weeks go by, months go by, years go by, and you're still, still feeling, or you're not even feeling anything, but when you get the blood pressure cuff going, it's like, oh, we've just been chilling at 180 over 110, cool. And people will be completely fine. People will be 220 over 110 and completely fine. I'm the one that's having a panic attack deep down inside, and I'm like, just look calm. Yep, yeah, your blood pressure's just a little high. We're just a little high.
Don't spike their blood pressure. Don't create panic. Don't create panic.
don't create panic. Don't create panic. And so that's probably the bigger if take home message is, and not everybody is going to feel that on performance enhancing drugs. Weight also has a huge role in that. So some people just, because a lot of bodybuilders also want to gain that muscle mass, some people's bodies just can't hang and the blood pressure just goes up, even if they aren't really on a whole lot of stuff. TRT doses, it's the weight that also really kind of can creep up.
That was something, so we had Nick on here last week, and that was something we talked about very briefly, was, both he and I being people in the bodybuilding realm, even just the personal experience of being at a high body weight. PEDs, aside, just being a large human being that maybe doesn't even have a lot of body fat, but when you're just heavy enough, it's enough strain just on your body. Like I sort of say most of this stuff self-deprecating, because I find it kind of funny at times, because I'm like 5'10" and I'm 270-ish. But yeah, I know. But it is something where I run this constant sort of analysis of making sure that things are okay. As funny as it is to be the butt of the joke, you should be aware that being that body weight is very stressful, and you almost need to have more things kind of in the checks and balances to make sure that you're healthy.
Oh yes.
I'm sure Mike must have run through that, because he's 5'6" and was 240 or 250 at his heaviest ballpark. Yeah.
I think his, at one point he was a natural 270.
It's a big human being.
Yeah, it's a lot.
Big boy.
Yeah.
Follow-up question on blood pressure, if you don't mind. Because I know that sometimes that which is normal or optimal or recommended changes. Have there been any changes or updates to, I guess, what is considered the normal range or the healthy range to blood pressure over the course of the past few years?
Yeah, I remember being trained sort of at the end of the time where it was sort of definitely 140 over 90, you want to do something about it. And I want to say that after, I think 130 over 80 is sort of now the cutoff of you really want to get, I think 135 over 85 was pre-hypertension or hypertension 1 or 2. I forgot the categories, but I think really trying to make it optimal, anything less than 130 over 80 is the place to be. You start creeping up into 140 over 90, and it's already just sort of a not so great time. So
that's really good to know. And then so it's actually kind of funny. So I was talking. So I live in Geneva, Switzerland, and I made a friend. I made one of my first local Swiss friends, which I'm really stoked about. And he's a physician. We went for a run. We were talking about a bunch of different things, and then I told him, I was like, I want to start measuring my blood pressure on a regular basis, for a variety of reasons. There's family history. I also run a little bit on the anxious side of things. If you haven't, you can't tell. But anyways, I was just like, oh, that would be a good thing to do. And I know it's one of the big rocks. If you're going to track one thing on a regular basis, it would be blood pressure. So you'll be really proud of me. And I'm not actually making this up. I actually picked up my blood pressure machine this morning.
Oh, hey.
Yeah.
My man.
Popped that thing in my bike and rode it back here. And I'm going to be starting to measure myself as of tomorrow morning, which is where my next question is coming from.
Yeah.
Which is, let's say someone wants to monitor their blood pressure to kind of see where they're at. I've heard that measuring it just once is not necessarily a great strategy. And so how would you approach if someone wants to get a good feel of what their blood pressure average is at?
Yeah. I think even measuring it 1 to 2 times a week is still like totally fine. I think if you were in more of a bodybuilding type space where the risk is a little bit higher, I think once a day, a couple times a week. I think it sort of similar to weighing yourself. There are some people who weigh themselves a couple times a week every day versus, 1 to 2 times a week. I think just consistently checking it is more key than just, should I do it every day? Should I not do it? Like if you do it, consistently for 3 weeks and then drop off the, planet, I think it's less helpful than if you are consistent. Like do something that is manageable for your schedule. And I think keeping in mind, having both feet flat on the ground, sitting upright, having your arm out, sort of at kind of heart level, not letting your arms sag, next to your, by your side. I think those are also important things to keep in mind when you're taking your blood pressure. And the last bit is making sure the cuff fits. So I think that's more of a Ryan thing to note.
I have to buy
what are you saying? What are you saying?
I'm sorry.
What are you saying? Come on. It's fine. I know. It's fine.
It might be a large or like on the higher end of the regular, maybe a large, but like there are, I'm thinking Ryan with like a double XL or a thigh cuff. Sometimes, to be considered. I have brought out thigh cuffs all the time when I was in the hospital. So you just got to find something that fits and kind of fits within the lines.
As an aside, because that it is not necessarily the blood pressure cuff, but the arm size, leg size thing. My old elbow sleeves are Shannon's new knee sleeves. I can't fit them up my arms anymore.
That's a good sign. I mean, that's good.
And that's what she wears to squat. So
amazing. Amazing.
Just, I don't know. Do you have a hard cutoff time, Christle, by the way?
No, I don't.
Cool. There were just shifting gears a little bit because there were some other things we wanted to talk about, again, that were not necessarily just pharmacology related.
Right.
So still maybe a little bit on the kind of the physician side of things.
Yeah.
Obviously, you work with the U.S. Figure skating team, correct?
Yeah, I do.
So are there any, highlights of that experience working with, Olympic level athletes? Anything in particular with, the athletes themselves or being a part of kind of a bigger competition like that?
Yeah. Let me clarify. So I 1 to 2 times a year I travel with the team for a week. I travel on a Monday, and then there's practice sessions, and then the competition's usually Thursday, Friday, Saturday, depending on how many entries there are. And so for the most part, I cover the junior figure skating circuit. So these are much younger athletes who are not quite at the senior level yet, kind of a little bit earlier in their experience. And then I also cover synchronized skating. So imagine like 20 skaters just trying to, all be on the ice at once in a coordinated fashion, like synchronized swimming, but on ice. So
wow.
That sounds really dangerous. Like someone's going to get cut real bad.
I do worry about that. I do, thankfully, knock on wood, everybody's been, super, like nothing too crazy has happened, but I really love the, just watching them at their sport. Like I was not a figure skater. I feel like everybody has asked me that, like, no way. I was overweight and not very athletic, so didn't have access to skates back in the day. So I love just, watching them be graceful but strong at the same time. I mean, you're twirling, you jump up your own body weight, and then you have to land very perfectly. Can only imagine the nerves that it would take to just, look very graceful and put on this. It's very similar to bodybuilding, where like there's a performance aspect to it, and kind of getting through each move very smoothly. What I also like about synchronized skating is the team aspect to it. Like, I think there's just a really awesome vibe to see like this group of people kind of coming together as a team. And so I get that, experience, on that end, like really just there's a different element to it when you are sort of in a team sport versus an individual sport that I also appreciate. But then you've got, I think overall with those athletes, they're just, what I do appreciate is just their level of dedication and how easily they don't let things rattle them. Even as young as they are, like, I definitely personally, wouldn't have been that mature. I wasn't that mature at 13 or 14 or 15, I wasn't even that mature at 18. So these people have, seemingly just, have it together. They are thinking ahead. They're, always really respectful. And so I just am always impressed, being given a chance to sort of work with that, environment. Like, I'm always just, any person who's half my age who has their shit together, I'm always like, dude, you're just awesome. Like, and the parents are so nice too. So, I really get to know who they are and who their families are as well.
That's really cool. Are there any parallels, like, as someone who's competed in powerlifting? Mm-hmm. I think have you competed in BJJ?
Not yet.
Okay, not yet.
That's coming up, but
it's coming
soon.
But as someone who has an athletic background, but not necessarily in this sport, mm-hmm. are there any lessons that you pull from your own competitive experience that you use with these athletes?
Yeah, I think, really trying to make sure that let them know that if they need anything, I'm here for them, but I'm also not here to step in their way, because I know that, like, this is competition time. Like, everybody has their own, like, this is my mindset. Like, I'm going to listen to music. I'm going to do whatever. Like, I'm not here to mess up your routine. So until you need me, I'm just going to be in the background, like, hanging out and, like, keeping an eye on the ice. And when you need me, just give me a call and I'll be there, and we'll do whatever we need to do to get through to whatever issue we have. So that's one thing that I think to keep in mind. And then a lot with, I think a lot of conversations I've had has also been with nutrition, thinking about using food as thinking about fuel, and thinking about maintenance calories, and thinking about getting protein, getting good protein intake, and how important it is to strength train to build muscle, particularly in the off season, and thinking about how to periodize training, I think are also things that I've picked up as a powerlifter, as an athlete, that I haven't necessarily had conversations with the athletes themselves, but I've always had those sort of in the background when talking to strength and conditioning coaches who work with the figure skating athletes, with some of the team leaders, some of the parents, because I think it's important to know that, hey, like, we, having a good relationship with food and not trying to, diet ourselves into the ground, dieting ourselves into the ground is not helpful for sport performance. So I know that can be a very sensitive topic. And when I'm out there on the ice or when I'm there at work, I always keep in mind, like, I go by example. So I will, bring all of my food well balanced, or if I am stuck in, some other country, like, just making as best of a choice as I can to keep things balanced. And then eventually we do have a food conversation.
Something else I was actually just thinking, talking kind of in the sports realm.
Mm-hmm.
So my background in sport was originally hockey. Mm-hmm. And as I was leaving the sport, the conversations around concussions were really starting to become prominent.
Yeah.
So, like, I distinctly remember times where I got hit in the head, completely lost my peripheral vision, sat on the bench until it came back, and then just continued to play. like if I had to guess, I've probably had 5 or 6 concussions that at the time would have never been diagnosed.
Yeah.
So obviously there's not necessarily contact in skating, but falls and whatever else happen, or maybe other athletes you might deal with. Is that, like, the concussion conversation, is that something that you're on the lookout for? Are you, cautious about those types of outcomes with those athletes?
Yes, and yes. I've seen concussions happen in non-contact sports like swimming. And so, or I guess you would think that it wouldn't be a contact sport, but I guess if you're practicing in the same lane or trying to so that has also happened. Cause I was like, at first I was also kind of like, concussion while swimming. How does that that can be a thing. I'm always, concerned about that, and I'm always on the lookout for that. And I think our approach these days, as more and more data is put out there, we're taking more of a more improved approach on it. Not just like, oh, hey, you lost your vision, like now it's back, get back in the game, son. Keeping people out, which is also a difficult conversation. There have been athletes that I have come across who do not like hearing that, they're being pulled out of a game. But sometimes, you really also need to think about the long-term effects of, getting hit in the head hard enough that, there's no sport worth it if in the end, you have all sorts of neurological problems down the road.
Totally. And concussions seem like they're one of the injuries that are perhaps the least well understood, and by extension, the least well managed. Would you agree with that?
Yeah, and I was just thinking about it. I don't cover boxing, so I don't know how, I honestly don't know how my stance would change if I was a physician who covered boxing. I think that would be, and I don't know a whole ton about the sport, or I haven't really talked to other colleagues who do ringside, or MMA, which also has striking. So I don't, thankfully I don't cover them, but I would be very curious to see what their take is on concussion management and where is that fine line? When do you stop a game? When do you stop a fight, etc.?
Well, there was actually a case, I can't remember how long ago it was. Are you familiar with Rowan's law, ET? So I don't know if you've heard of this, Christle. So it's a law in Ontario, at least, called Rowan's law, because there was a high school rugby player who got a concussion, I believe, in the first game of a tournament, played another game, got another concussion, and essentially had subsequent concussions over a couple of games, over a couple of days, went in a coma and died. So the worst part is that was my old high school.
Oh boy.
So I graduated with that girl's sister.
Oh boy.
Yeah. So after that, ET, you can correct me if I'm wrong here, but essentially it changed the rules on if there's a high school athlete that presents with any kind of concussion-like symptoms.
Yeah.
They are out immediately.
Yeah.
There's absolutely zero tolerance for them playing.
Yeah.
I think that was a huge wake-up call, I think, for a lot of people.
Yeah.
Just how severe they are and how quickly they compound.
Mm-hmm. Mm-hmm. Yeah. No, and it's always, particularly if somebody is, under 18, they're not even, a full adult, it hits, harder, if that was a terrible analogy. That's a terrible choice of words. That is a terrible choice of words. But it's a lot more tragic than if it was, somebody who is 35. The general public will, feel some type of way about a teenager dying due to sport than, somebody who's old enough to make sort of their life choices.
Yeah, totally. Yeah, it's interesting that this is coming up because in September, I think it was 4 or so years ago, I was consulting on the case of a woman named Katrina O'Neill, who I stumbled upon on Facebook to make a really long story short. And I noticed that she had really, her concussion symptoms were just not getting worse. They were getting, they weren't getting better. Excuse me. They were getting progressively worse, even though she was actively seeking treatment.
Oh boy.
And I knew this guy in Ottawa that I was like, I feel like he could help. So I essentially hooked them up, brought them together, connected them. And then her recovery over the course of 5 days, she went from needing 2 pairs of sunglasses, noise canceling headphones, not being able to speak without a stutter. She needed a walker and all those things. To in 5 days, she was sprinting.
Oh, wow.
And I remember distinctly the Rowan's Law. I hadn't heard of it until on like her 3rd day, she announced to the world that she could speak, really, by making a statement on Instagram about Rowan's Law. And it was a very powerful message, because this woman had been suffering and hadn't been progressing in a positive manner for so long, and then finally something clicked. And it was in that moment that for me I really felt like, wow, of all the injuries, it really seems like there's a huge gap of understanding here. And that's why, I think like the protocols, like you mentioned, Ryan, that we have in Ontario now, which is like the moment you have any type of symptom, like you're out. I think that's a good step to take. And who knows, maybe it's too aggressive. Who knows, but I think that like in time, excuse me, I just smacked my microphone. In time, the response will calibrate itself as we gather more data and, learn through trial and error. But it's wild how debilitating it is for people. It's and how inconsistent it is, right? Because you're like, it can be, and it's wild.
Yeah, you have the questionnaire for like symptoms, like how you rate your symptoms on like on a scale, and it's like, insomnia, like headaches, like vision changes, like I feel exhausted all the time, or I can't go to sleep. Like it's, everybody's different, so different that I can't even begin like, on average, like, this group of people tends to experience a concussion like this. Like, no, everyone is different and everybody progresses at a different rate. I don't know what the concussion protocol is like in Ottawa, but I think a huge thing that I hope is like has been, kind of seems like old news to people is the idea of like bed rest. Is not exactly like keeping people out of their sport, totally appropriate, but in terms of like making sure they get up and start walking, or trying to like, get on, the treadmill, do a little light jogging, like the road to activity is a lot more, keeping them active. It seems to be a little bit more helpful overall in general, compared to just like, oh yeah, you have all these concussion symptoms, just like, stay at home, wear your sunglasses and like not do anything.
It seems to be the case too, not even just with concussions. I feel as though I've seen this trend in kind of the rehabilitation space of like, do what you can as quickly as possible. Knee injury, back injury, brain injury, but like just getting some kind of input immediately, so long as it's tolerable. I think, what's his name? Dr. Andrea Spina, FRC, was kind of a big part of his messaging. I did a couple of his courses years ago. And a lot of it was, the athletes that they work with. I think they had a couple people that were post-ACL, post-op. And, they just had them doing like knee circles the second they woke up after surgery. And I think they had a case where they had someone that was like returned to sport like 2 or 3 months post-ACL repair.
Oh, wow.
Which is crazy. Like I could be a little bit, but it was like at a very aggressive timeline.
Right.
And it was, they just had this person doing something immediately.
Yeah. There was I covered a motocross event a couple years ago, and the physician I was working with, she, and they suffer concussions quite a bit too, being in that sport. And I saw her, this kid came in, fell off a bike, hit their head. And first thing you do is have them chug Gatorade and have them actually think about what events like were happening leading up to the fall and hitting them on the head and what has happened afterwards, and making them think through that and say that out loud, which is a little bit of a painful experience because you're like, my brain is all sorts of whatever. But she had said that that seems to speed up the recovery process compared to just sort of letting them be and letting them, rest immediately. Like, you're getting that brain thinking, forcing it to kind of think. So it's sort of, instead of, just as important as it is to kind of get up and move around, like keeping your brain active, especially immediately after the concussion happens, seems to speed up the process. I keep meaning to look up to see if there's any literature supporting that. It's not really, I don't think it's doing, harm to a rider to force them to think about stuff, but.
Mm-hmm. Yeah. And even like, where my mind went when Ryan brought that up was, when you brought that up was like, even within the context of trauma. I know we're kind of going, with GLP1, skating, motocross, and trauma all the way over there. But you think of like getting someone to work through in their mind and then subsequently verbally traumatic events, seemingly just kind of helps with the emotional charge of the thing, which how would I say? Ends up having a therapeutic effect, but I don't know if we necessarily understand the exact mechanisms, but I don't know, that's where my mind went.
Yeah, they seem to, because you have shifted the focus to something else, something that I actually have to work hard at, because a lot of people don't remember all the events leading up to, the concussion. So, instead of like crying or having some sort of feeling about what else is going on, it's like, oh God, I got to think about this. Like, all right, I was riding and I was on the turn one, and then I came across and like this other rider like knocked me over, and then I felt like it's painful. Like, they're painful, like feeling pain, having to go through that and like thinking about it because they don't remember it. A lot of times they don't remember those events. Yeah.
So I think we're starting to get closer towards the end of our time together today. I know Ryan has some rapid fire questions for you.
Oh boy.
Ryan, you ready to go? Christle, you ready to go?
Yeah.
So just like, we've got 10 questions.
Okay.
First thing that pops into mind. Cool.
Okay. Yeah.
It's like a quick get to know you section.
Okay. Yeah. I'm down. Let's do it.
All right. Question 1. What is your favorite book, movie, and concert?
Ooh, my favorite book is, recently 5 Dysfunctions of a Team by Patrick Lencioni. Very important thing about teamwork in the workspace and like work culture, and how important it is to organizational health is super important. The movie, I guess I would have to say Bridesmaids. I like that one. Nice. Every time I'm on a flight, I'm like, all right, this is the go-to.
That's funny.
And then concert. Been to so many good concerts when I was younger. Probably 9 Inch Nails with my gosh, David Bowie.
Second question.
Yes.
Favorite and least favorite food?
My favorite food is lobster mac and cheese. Lately. Well, I've been having a craving for that lately.
I think you got that in London.
Did I?
I think you did.
I was thinking about it.
Remember that. Yeah.
Yes, lobster mac and cheese. And then my least favorite food, honestly, I would say fudge. Just the texture. I know it's the texture is just like, it's too soft and too rich. Like, if I want to like bite into something rich, it would be like chocolate cake with like layers into it. There's like no, like, even with the nuts, even if you added nuts to it, it's still like, and then it leaves this gritty taste in your mouth. So
Yo, before we move on, I have to say, like, lobster mac, I concur. I haven't had that in so long, but your boy has a craving right now. I got lots of food drive for lobster mac.
Oh boy!
Just saying.
Question 3. Proudest moment outside of business.
Man, I am terrible because I am one of those people that's just sort of like something good happens and I'm like, oh yeah, that's cool. What's
Yeah,
next?
that should have happened.
Or
Yeah.
like, no, what's next? Like, what's the next thing? Man, I guess I would have to say graduating from fellowship because that was like it. I was like, there's no more training. There's no more, working these insane hours. So yeah, 2021.
Question 4. Favorite sporting moment of all time? Either your own or as a fan.
Oh, yeah. I'm not a great sport fan, to be honest.
Nick's was Michigan, by the way,
course.
which is obvious. Yeah.
I mean, if I had to choose, I think my brother, like in the early 90s, UNLV men's basketball was super, like, popular and good. And my brother, who's 9 years older, was a big UNLV fan. So, but I would say, winning my local powerlifting meet and getting drug tested was probably a highlight. Like, you're good enough to be drug tested. Yes.
That's a big moment.
Question 5. What 3 values guide you?
Ooh. Think, don't ask somebody to do something you wouldn't do yourself. Always think about the pros and cons and the long-term ramifications of your decision. And as a leader, taking an interest in your team as an individual, just getting to know them, even with seemingly easy questions like this, is super important. And I think it shows that, hey, you actually value who they are and what they enjoy.
Question 6. Favorite go-to food during a diet break?
During a diet, other than lobster mac and cheese.
Other than lobster.
It could always be just lobster mac.
lobster.
You can double click on that if you want. It's all good.
Ooh, you know what I had recently that was pretty good is the viral Dubai chocolate. It's where they take like pistachio and I think it's the pastry filling that they use for baklava. They roast it in like coconut oil. They mix it up with pistachio paste and then they coat it with chocolate. And
oh my God.
Search that on TikTok. It is viral Dubai chocolate. It's in Michigan. It's been selling like for as cheap as $5 and for as much as $25 for a bar.
Question 7. One misconception about Dr. Mike.
I've seen a lot.
I'm sure.
I think people seem really surprised that he's married online, and I don't know if it's sarcasm. I legit
Probably because he makes so many sex jokes.
Yeah,
to be honest.
yeah. Fair enough.
Question 8. Favorite vacation spot.
I would say not in terms of spot, but I guess most recently we stayed at a very nice hotel in New York City. We stayed at the Aman, New York, and it was just quiet-ish. Like, it was just sort of like, we were in New York, which is really busy, and like all sorts of stuff going on, but to be able to kind of, I don't know, I remember sleeping in, and like taking a nap in the middle of the day, and it was like the best thing ever. That sounds really sad saying out loud. Like, I got to take a nap in the middle of the day. Like, you just...
I'm very pro nap.
No.
I'm
I can't
curious.
do that. I can't do that with a dog. We have an old English bulldog, and like,
Cute, yeah.
she's adorable. But she like wakes me up. Like, I get up to take care of her in the morning, and then I can't go back to sleep.
So there was the dog piece. Was it also just that like the hotel did such a great job of creating a peaceful environment, or
A peaceful, dog-free environment.
there
It's
you
like
go.
it,
That's
yeah.
the secret. Yeah.
Question 9. City or country that you would love to visit that you haven't?
Ooh, that I have not. Right. Well, Tokyo is on our bucket list. So
And our final question. What's one hard truth that fitness professionals need to hear?
the hard truth is that, hunger drive is a real thing that it varies from person to person, and it's not always just willpower. I know that it's hard when you have clients who, some people underestimate their intake, but that drive to eat is a real thing, and it's not easy to navigate through. So just be respectful about, where people are coming from.
We finally came full circle.
I love it.
Very
Yes.
I love it. I have one question that came up. And Ryan, you said it was going to be the last one, and I apologize.
It's all right.
Stealing your thunder.
Some asterisks.
That's right. Yeah. I put the ass back in asterisk.
Hey.
It's 3 today. I'm curious. What's a question that you wish people would ask you?
I feel like people usually ask me a lot of questions. I
want fucking fewer questions.
No.
Leave me alone. I want to have a nap in the afternoon.
Without my dog, no. I love it. I can't really think of anything off the top of my head that I'm like, yeah, I wish people would sort of ask me that, because I feel like, people have asked me a lot of amazing different questions about whether it's my story, whether it's, medications, like as a physician, as a fitness professional who works with clients or who on Ozempic or who might work with Ozempic. They'll ask me questions about being married to Dr. Mike. I feel like I can't think of anything off the top of my head where like, I wish more people asked me that, to be honest.
All right.
Maybe that's a good thing.
Maybe that's a good thing. Yeah, people really care about learning about you. I think it's a good sign. It's been genuinely a real treat getting to know you. This is the first time that we met was today, it's been so fun. It's been so fun getting to know you, and I really appreciate you sharing all of your wisdom that you've accrued over the past few years. Like not only just your own experience, but also as a physician with us today. Really, really grateful for your time.
Thank you so much for having me.
It's been a total pleasure. If individuals want to follow you and want to learn more about the information that you're putting out there, where could they do so?
On Instagram, I'm at dr.christle, CHRISTLE. I am working on some projects right now to kind of help with some things here and there that I can't really reveal just yet, but I am looking forward to soon enough kind of putting that into motion. So,
is there a timeline associated to these secret projects?
We're thinking of, like probably early 2025.
Okay.
So
not too far
coming
away.
up soon, not too far away.
Nice. Would you be opposed to coming back on here and talking about it?
Oh, for sure. I would love to.
Sick.
Yeah.
Amazing. Ryan, do you have any other questions or any comments before we wrap?
I guess I'll see you in Vegas.
Oh, you going to the Olympia?
Yeah, we fly on the 6th. So I'm there for like a whole week.
Oh, awesome.
Yeah.
For sure. We're definitely going to have to, connect, and because we'll be there. We'll be there the week leading up to the Olympia and then the week after.
Nice. Okay.
Solid.
Beautiful. Well, thanks again, Christle. Honestly, it's been such a treat. And we will chat again, hopefully in the near-ish future, to talk about your secret projects.
Definitely. Thank you so much for having me.